exactly a pneumonia looks like, but still we will get into a little bit of more details about recognizing a pneumonia in this chapter today. So what are we going to deal here is we have some general considerations, then we have some general characteristics of pneumonia, patterns of pneumonia, and we are going to learn about a particular condition called as aspiration, and we are also going to see how pneumonia resolves, right? So first thing, what you have to understand in radiology, I think what this might be completely contradictory from what you have learned in your other classes. First thing, you are till today, what you have actually learned pneumonia as a disease, right? It is some kind of a respiratory tract condition which actually causes breathing problems related to cough or sometimes excessive sputum production. So that is what you have learned, that it is some kind of a disease. But while it comes down to radiology, you have to understand one thing, that pneumonia is a condition that actually, yes, of course, it is related to the respiratory system. Of course, it releases a lot of mucus and there will be productive sputum. But generally, when we try to recognize the pneumonia on a chest X-ray, we don't pose it as a disease. We generally find it as a pattern, or we find it as a radiographic finding. So most of the times, anytime when a radiologist is writing the term pneumonia, it generally means to say he is finding some kind of an opacity, a radio opacity, which is technically called as a consolidated. Bronchi are not filled up with exudative fluid, okay? Since the pathogen is entering down through the bronchial tree, if the pathogen did not settle down in the bronchial tree and finally went down to the destination of alveoli, so these bronchus are completely normal, and that the other area became completely white. So that one will eventually form an air bronchogram pattern. We will understand what exactly I'm talking about in the next slide. But first see that in an air bronchogram, you have to understand that the bronchi themselves are completely not filled up with this inflammatory fluid, whatever that has been released by the pathogen. Okay, so bronchuses are quite clear. Alveoli are filled up with an inflammatory exudatory fluid. Okay, that's how it happens, right? Air bronchograms should be more likely be visible when the pneumonia involves the central portion of the lung near the hilum. Okay, just remember one typical thing here. Air bronchogram is not technically very specific for pneumonia, but it is generally seen in pneumonias itself. Doesn't matter what pneumonia, generally an air bronchogram pattern is present in pneumonias, but it is not entirely specific for pneumonia. So there is a difference, because this is one of the biggest problems. I think in the previous classes, what we have said, it might be a characteristic of a pneumonia. Air bronchogram pattern might be a characteristic of pneumonia, but it may not be specific for pneumonia. Okay? Because of pneumonia, who do not gram pattern also. So they are more likely to get visible if the pneumonia involves the central portion of the lung near the hilum. So air bronchograms are generally seen over only the lung that is involved near the hilum, because the trachea, the pathogen enters through the trachea, and the alveoli in near the hilum are completely filled up, and then the bigger bronchuses, let us say the primary bronchioles, Okay, the primary bronchioles are bigger and patent. Okay, but they are technically very much visible over the peripheries because they are much smaller and much narrower. Okay, so air bronchogram is generally is present on the central portion of the lung near the hilum, where the bronchuses are bigger, something like the left main bronchus or the right main bronchus, which is the biggest bronchus, or the primary branching bronchuses. Okay, something like upper lobar bronchus or the middle lobar bronchus or the lingular bronchus or the bronchus intermedius. So only if they are being involved in those areas itself, you are going to find an air bronchogram pattern. But if you are trying to find out the terminal bronchus that is present down in the lateral segment of the right middle lobe, no, it may not be obviously visible and you may not appreciate the air bronchogram pattern. But still, it is a consolidation as well. Okay, we'll see. Now, let us try to understand here. We are trying to look at this particular X-ray. In this X-ray, I can see that there is some kind of a hazy, fluffy density, which is confined to a single lobe. And particularly, I'm looking at the left upper lobe here, right? Okay, there is a poorly unmarginated, okay, poorly defined or unmarginated hyperdensity or a patchy density, okay, a single patchy density that is present in the right upper lobe. When I'm looking close enough, when I'm looking closely, you can see here there are some kind of radiolucent branching structures that are actually overlapping with this density. Yes or no? So this is a localized, poorly hazy, unmarginated density that is present in the left upper lobe. That is the first finding I made. Okay, so this one actually suggesting me that I am looking at some kind of a hazy density or I'm looking at a consolidation type of pattern. Okay, but what happened if I looked much more closer? What actually happened was, you see here, I can also see a radiolucent branching like structures that are being overlapping this hazy density. So a radiolucent branching structure that is present within a hyperdensity is called as an air bronchogram. Did you get it? So here I see this radiolucent structure that appearing down as black tubes are indeed nothing but your left upper lobar segmental bronchial branches. See, left main bronchus, and left main bronchus eventually divides down itself down into two segmental bronchuses in the upper lobe, which is the right apico-posterior segment and anterior segmental bronchus, right? So this is what I'm looking at. Yes, of course, this is pneumonia. Yes, of course, this is involving down in a single lobe, but still I am looking at a radiolucent, okay, air-filled bronchi within a fluid-filled alveoli within that segment, within that lobe. So this is actually called as an a bronchogram pattern. So that is what I'm looking at here. So this one, such kind of a finding will eventually say that this is an left upper lobar pneumonia. See, did not this, even if I told you that this is a left upper lobar pneumonia, still didn't mention, just failed to mention if this is a bacterial pneumonia or if it is a viral pneumonia or not. So we have to investigate further to know which kind of a pneumonic pattern is this one. So we have to have some kinds of hints. Because we will be dealing about such kind of hints, what kind of an organism we are dealing up with here. In the history, we came to find has some kind of a pneumococcal pneumonia. So generally you see here an upper lobar pneumonia generally is a pneumococcal pneumonia. It's something that's how I remember myself, if what kind of a pattern I'm looking at. If there is an air bronchogram pattern with the upper lobar unilateral consolidative areas, I make particularly pose it as a pneumococcal pneumonia. So that is how I'm doing it. Is this clear now? Okay. Yes, I recognize it as upper lobe by bronchus itself. Yes, of course, I'm looking at. You see here, you must be familiar about now the classifications of these bronchuses. I should be able to also classify the whole area depending upon the bronchial distribution. It should have been by heart by for you guys now, right? You should have known to differentiate the segments already now. Okay, since we know all the segmental classification, since we know all the classification of the primary, secondary, okay, middle and tertiary bronchioles, we should be able to now differentiate every place depending on the science of bronchuses itself. Okay, distribution, you should already be prepared with this one. Okay, right? If not, if you are not unable to do it, yeah, it will get more difficult on a CT, and you will be failing out to recognize it as the wrong lobe. Okay, right? We'll practice it. So generally, you have to also remember here one thing, that this one is this kind of consolidation or this kind of uh, you know area is generally homogeneous. Homogeneous in the sense it is equally denser all the eight place, okay, except for the radiolucent areas that what you see in between. So you cannot technically call it as a heterogeneous one. Okay, heterogeneous one, this should not have such kind of a branching pattern. Okay, it should not show the pattern of the bronchuses or the any structures. So you have to as a radiolucent branching structures present within a consolidation area. So that is what an air bronchus is. Okay, entirely different from this one. Heterogeneous will have a mixture of black and white, even though this is a mixture, but you see the branches here. So that's the reason I'm calling it an air bronchus present between a homogeneous density. Okay. See, no difference between a pneumonic consolidation and pneumonia. You are both, you are, okay. Consolidation is not by cancerous cells. That's what I'm here. Okay. Pneumonic consolidation, whenever you see called as pneumonic consolidation by pneumonia, yeah, both of them is the same thing. Okay. You're grammatically making changes to that sentence, but you are not talking them as two different entities. So don't confuse yourself as pneumonic consolidation and consolidation by pneumonia. There is nothing difference between them. But generally, what the other thing what you have asked here is consolidation by cancerous cells. No, generally, if it is happening by the cancerous cells, we don't call it as a consolidation. We have to look at the pattern. Okay, that's what the patterns of pneumonia is talking about. Okay, generally, pneumonia resolves, but a cancer do not resolve. Even a cancer looks like a cancer, but a pneumonia cancer do not treatment, right? So that we will talk about that one. Okay, but generally we don't call it as as a consolidation. We use other terms to define that one. Okay, right. So general Cavitating pneumonia. Generally, if it is present and margins are in between, so it is unmarginally dizzy density, okay, fluffy density, and when it abuts the pleural, it will not extend. There is a pneumonia that is present in the lobe. It will not extend the phloem. fissures. It happens because the same way how the air in the right upper lobe is completely its own when compared to the air that is present down in the lower lobes. Okay, that was was also. Okay, when you are trying to assess the volume, when you are trying to assess the capacity, when you are trying to learn about the inspiration of this particular individual, you see here each lobe has got its own capacity. Each lobe can its own volume of air. So because air molecules from one particular lobe to the not pass over. Okay, it takes a hematogenous route if there should be a exchange of materials between these lobes. Because the lobe is already divided by their visceral pleural layers, right? So whenever if I'm pneumonia in a single lobe, yes, they do not pass the fissures. So if they are not passing the fissures, and that in only in such conditions, this pneumonia will be sharply marginated. A single lobe, here they will be fluffy, margins are indistinct, but if you move along the pleural surfaces, yes, they will be sharp because they beyond the the pleural. So unless if it is down the interstitial, particularly call it as an initial pattern, will produce prominent intestines and they spread to the adjacent airway and they also spread to the adjacent alveoli and air. So interstitial pneumonic pattern will have interstitial reticulonodular patterns, nodulations, as well as consolidative air bronchogram changes. Now, is this clear now? So, whenever also when I'm talking pneumonic pattern, I have to look at the patterns which kind of organisms present me up with interstitial pneumonias. Or when I'm talking about a particularly lobar pattern, okay, lobar consolidation, I should be looking at the diseases which actually cause such kind of pattern. So there are two types of patterns. One where the margins are completely indistinct and localized down only to a single lobe, okay, right? And there is another pattern that is called as the interstitial pneumonic pattern, okay, which actually happens down and spread to the adjacent airways and also has a characteristic feature of an airspace disease. Do not confuse yourself that lobar pneumonia and interstitial pneumonia are two different diseases. No, we are talking about the same clinical entity that is called as pneumonia itself. Yes, obviously, I'm talking about a clinical condition called as pneumonia. But here, when I'm talking about lobar pneumonia, which means to say I'm talking about its pattern that is called as consolidation or right bronchogram pattern. When I'm talking about it, writing a term called as interstitial pneumonia, it means to say I am looking that is involved along with airspace. Did you get it? These are not two different diseases, not two different clinical, different where either progressing. So I'm talking about the pathophysiological progression, the micromolecular changes that is happening inside the alveoli. That is what exactly I'm talking about. Okay, it is not two different diseases, it is not two different diagnoses, but it is two different imaging characteristic patterns. Did you get it? Is this point clear? Do not confuse yourself with these terms. You get it? Is there any problem? I will be able to repeat that once again. Okay. Interstitial pneumonic pattern or consolidation and air bronchograms are diseases. All about particular. But when I'm writing the terms, I'm writing in a report about pneumonias or consolidations or interstitial pneumonia, please do not confuse yourself it as another disease. There is no diagnosis called as interstitial pneumonia. Okay, it is a pattern. It is a radiographic observation made by the radiologist. Okay, since the clinician will not be able to make these uh, uh, interpretations, so that's the reason as a physician you should be aware what radiologist is talking about. Is this clear now? Please respond, guys. Is this clear? Yes, no? Right. Okay. So what happens? Except for the presence of air bronchograms, airspace pneumonia is generally homogeneous density. So that's what we saw. It is a fluffy, unmarginated, okay, homogeneous, which means to say equally white density that is present. And in some types of pneumonia, especially bronchopneumonia, all the bronchi also get involved. Okay, the bronchi also get involved, and air spaces contains inflammatory exudates. See, now we are talking about different diseases. Okay, there are certain types of diseases which is called as bronchopneumonia. And pneumonia is talking about alveoli, only air space. Okay, only the particular alveoli. But there is another clinical condition. Generally, it is not called as clinical condition, but because it will be broadly called as pneumonia itself by the clinical doctors itself. Clinical doctors in the sense, the doctors who are treating the patients, not a radiologist. But for a radiologist, bronchopneumonia is entirely different, which means to say, if I'm writing a diagnosis called as bronchopneumonia, I am particularly talking about the inflammatory exudate passed over to the bronchi and also the air spaces together, right? So bronchi are involved, airspace is involved, which means to say I am talking that the pattern I'm looking at is wherever the bronchi is present, those are the areas I can see the airspace consolidations. Did you understand what I'm talking about bronchopneumonia here? If I say a thing called as bronchopneumonia, what I meant to say is that wherever the bronchi is present, the associated airspace to that bronchus is consolidated. So is this a localized disease or a diffuse disease? Is this unilateral or a bilateral condition I'm talking about? You tell me. If you understand, wherever the bronchus grows, okay, that is the place I am looking at an airspace consolidation. Exactly. You see here now, right now, you guys are understanding to get it. It is diffuse, it is bilateral. So how can I actually define bronchopneumonia? Bronchopneumonia are smaller patchy areas, okay, smaller patchy consolidations or perihilar opacities that are distributed all over the lung fields. So that became my radiographic feature of pneumonia. Did you get it? How did I understand what exactly I meant to talk about bronchopneumonia? Generally, the clinical diagnosis doctors won't write it as bronchopneumonia. Even if it is present in a single lobe, even if it is present in the whole lung, even if it is present down in all the lungs, both the lungs, the doctor will be writing down same treatment. But he is ignoring a point that is called as the progression of the disease. Did you understand what exactly how the radiologist report is helping the other doctor? He is saying yes or no. When I write a pneumonia, simply I may be talking about a single lobe, single segment, single lung, but I'm not talking about the diffuse pattern. But if I'm talking about bronchopneumonia, I am particularly suggesting the doctor to think that the reason for his productive cough is because of production of the inflammatory exudate inside the bronchuses, for which an antitussive medication will be of no use. So what is the medication I'm trying to prescribe to the patient? I'm trying to prescribe an expectorant to that patient. I am going to prescribe a mucolytic to that patient. I am going to prescribe an anti-inflammatory to that patient. Did you understand now how my radiographic report has completely changed the treatment strategy of this particular individual? Yes or no? If I have just written pneumonia, I might be talking about bacterial pneumonia and you will be giving down only an antibiotic and you will be giving down a cough suppressant, antitussive. But if I particularly wrote about the pattern which it is presenting, it has changed that the patient needs anti-inflammatories. The patient needs expectorants. The patient needs mucolytics. The patient needs oxygenation. Did you understand how I'm talking about here? The radiology report has completely down the treatment. This kind of understanding whenever it is working. Okay, is this clear now? Did you understand this point? What I'm talking about here? Okay. Yes, no, right. Okay. All other guys, what about you guys? Did you understand? It might be confusing, but listen it twice, you will understand it very simply. All right? Okay. Now, the other thing is that since the bronchuses are also filled up with this inflammatory exudate, you can also see that these bronchias are becoming narrower due to some kind of depositions in them. So which means to say in such kind of patients, I am also looking at atelectasis. So wherever this bronchosis is going, wherever there is, okay, wherever there is this patchy consolidation at the ends of air spaces, since there is also presence of an inflammatory exudate inside the bronchus fillings, so I will be having an atelectasis depending on them. So, which means to say pneumonia will eventually cause me dyspnea. Did you understand? If the patient did not have dyspnea and I am looking at a bronchopneumonic pattern, okay, so what do I understand from this? Let us say, let me give you a clinical scenario now, okay? The clinical scenario is something like this. A patient of 5-year-old, a patient of 5-year-old comes down to the OP department with a complaint of productive cough for the last 7 days and a low-grade fever. He does not complain any chest pain and respiratory distress. Okay, right? When I took the X-ray, I found out a bronchopneumonic pattern on it. So what am I thinking about here? What am I thinking about it here? Now let me give you another case scenario. A 15-year-old female comes down to the hospital with a complaint of respiratory distress, okay, with a complaint of respiratory distress, high-grade fever, and a productive cough for the last 10 days, okay. The patient also suggests that she did not get better with the previous medication. And when I took an X-ray, I am looking at a bronchopneumonic pattern. So now in both the clinical conditions, I am looking at a bronchopneumonic pattern, but as a physician, what am I trying to understand and differentiate these cases as? How am I differentiating these two persons and how am I understanding these two conditions and how am I going to change my protocols according to this one, according to the X-ray what I'm looking at? The radiologist has written bronchopneumonic pattern, which obviously means to say there are fluffy, hazy-like densities that are diffusely seen all over the lungs. That's what he meant. But how did my report change it? What are we going to do? Two different clinical scenarios with the same kind of pattern, but I'm saying that the treatment is entirely different. So what did you understand by the radiological report? What you should be thinking? No. Forget about the microorganism. I did not talk about the microorganisms yet. Yes, Reshma, you are entirely correct. You are talking about the progression and the current situation, and you are trying to understand what exactly is going on in this particular patient. Okay, so what am I trying to do? In the first patient, I will be mentioning that patient as infectious pneumonitis, bronchiolitis. Okay, the first patient who did not have the respiratory distress, only inflammatory component is going on. So do you mean to say, do I have to add bronchodilators to that patient? Particularly no. Do I have to add oxygenation to that patient? Particularly no. Do I have to add a nebulization and humidification therapy to that patient? No. So I will be giving down only anti-inflammatory to that patient. So what am I going to use? I'm just going to use the antihistaminics like ephedrine, pseudoephedrine, chlorpheniramine maleate, and I'm going to just give a normal, right? Okay. But in the second state, to understand, in the second patient, yes, it obviously shows me that I have to give a bronchodilator. It obviously shows me that I have to give down a nebulization therapy, right? Okay. You see here, exactly that, Aman, you are asking a very good question here. Unless the exudate is completely compromising the complete diameter of the bronchus, yes, the atelectasis may be seen or may not be seen. One single bronchus, one small alveoli completely getting deflated or getting atelectasis, which means to say the bronchus that is present near to it is already filled up with the mucus. So it actually depends on the progression or the pattern of the symptoms that your patient suggests. Okay, right? Yes. Whenever there is some kind of a filling within the bronchi, the related alveoli, okay, microstructure, related alveolar microstructure will eventually get atelectasis. That's true. But if it is weed, it will not be prominent until it will not be prominent to and visible to a naked eye until a larger area of the lung is involved. Okay. Yes, but still atelectasis is happening as a pathophysiological change, but sometimes we may not be appreciated it, okay, unless the condition is completely diffuse and broad. Okay. Yes, is this clear, Aman? Okay. No, you see here, if the mucus is filled within the bronchus, we cannot see air bronchogram. Air bronchogram are only air-filled bronchuses, which means to say they are completely patent. They are completely open. They are not filled up with anything. All the mucus that has been produced will go and eventually settle down and be there in the alveoli. Is that okay, Nitesh? Okay. Bronchuses are completely patent. Bronchuses are completely open in an air bronchogram pattern. Get it? Okay. No, you see here, first, alveoli did not get deflated there. You see here, alveoli got filled up. Aman, alveoli got filled up there. Okay. See, deflation actually, yeah, I know. I understand what exactly you are talking about. You see here, each one alveoli got deflated, one alveoli got atelectatic. So that is how the pattern is going on. Okay, it is technically a little complicated for you guys to understand at this level. Yes, alveoli is nothing but the alveoli getting deflated. Yes, that is actually called as an atelectasis. So what your question is that, okay, if the alveoli has already fluid in them, so that's what I'm talking about. First here, the bronchuses has got fluid in them, then that's causing actually the atelectasis. So that's the reason I'm calling this condition as bronchiolitis rather than calling it as bronchopneumonia. Did you understand this, Aman? The first clinical condition, yes, also will show up a bronchopneumonic pattern as well, But right now, I am calling that condition as bronchiolitis. Okay, infectious pneumonitis or bronchiolitis, which is entirely different from a condition called as bronchopneumonia. Did you understand? Both of them will show bronchopneumonic patterns, but one is bronchiolitis, other is pneumonitis. Did you understand? There is a difference between them. Yes or no? I'm talking about two different clinical scenarios and two different clinical diagnoses and entities, but all of them fall under the category of pneumonia itself, right? I guess now it should be much more clear. Did you understand? Right. Okay, let's move on. Okay, the next thing is that you look here. First thing we have to understand, last time we were learning about the Siloti sign. I think by now you have already understood about the Siloti sign. But if you did not understand about the Siloti sign, let me recall what exactly I'm talking about. So Siloti sign suggests that, okay, when there is a blurring between the edges of two anatomical structures. Listen carefully. If there is a blurring that is present between two anatomical structures, it is attributed to a pathology present to the anatomically related structure in that area. Okay, if there is a blurring between the edges of two anatomical structures, the problem is present down in the anatomically related structure. For example, to say, look in this picture, when I cannot actually, if the normal X-ray, if you are thinking about the normal X-ray, where the left-sided heart shadow should be present here, right now, the edge of the left heart border, okay, the edge of the left heart border is not clearly visible, which means to say the edge of the left heart border has been blurred away by this homogeneous density that is showing down in the lower lung field. Okay, but what does this suggest? It is suggested that this one, the Siloti sign, now exactly this is called as siloting. Okay, this homogeneous density is siloting with the density of the left border of the heart. That is first I came to understand. And then, according to my definition, the problem is not present inside the heart. The problem is present down in the anatomically related structure. So what is the anatomically related structure of the left heart border? It is the lingular segment indeed. So the problem is present down in the lingular area of the lung, and particularly speaking, inferior lingular segment. So I pose this patient as a lingular pneumonia. Did you understand how I used the Siloti sign here to define it? Okay, right? So even if I see it here, it may appear on the first visualization itself. On the first visualization itself, it may look like as if everything is present down in the lower lobe, but obviously it is not present in the lower lobe. It is present in the lingular segment. So this is the differentiation you should be able to make. Okay, so that is how I am using a Siloti sign. But on a general physician, what actually happens is that if I'm looking at this, I will pose up as lower lobar pneumonia, right? And I will, okay, if I particularly remember down in my clinical classes, if I'm saying, okay, but this broad gram-negative, most gram-negative bacteria are lower lobar, okay, if I'm remembering like that, see, I am obviously mistaking. This may not be such kind of a pneumonia. It can be entirely different. Okay, you see here. So that's the reason we are trying to use the Siloti sign, and that's the reason radiologist report plays a very important role in the clinical setups. Now, this is the Siloti sign. Let me repeat it back once again. If the borders of two anatomical structures are blurred, it suggests that the problem is present in the anatomically related structure, which the blurring has abated. Okay, so here I cannot see the left heart border. which means to say the problem is present down in the anatomically related structure. So the anatomically related structure that has got a relation with the left heart border is indeed so because this homogeneous density are obscuring with the left heart border, I came to understand that is indeed a pneumonia which is present in the lingular segment itself. See, no, generally, okay, you are logically correct, Aman. You are logically correct. But generally, can you see any lung borders unless there is a problem like pneumothorax? Visceral pleural lines are generally, okay, visceral pleural lines are generally not visible. The lung borders are generally not visible, right? So you mean to say that if there is a problem like congestive heart failure, if it is taking up a large area along the cardiac space, right, in the mediastinum, which will obviously push down the lungs. Yes, right, obviously, yes. But you see here, lungs do not have a density for themselves. Lungs are obviously looking black. Yes or no? Lungs are obviously looking black. So what can I find? I will be looking at the heart shadow, which is much more bigger as that. But yes, logically, yes, congestive heart failure and a hypertrophy patient or a cardiomyopathic patient obviously will take up the airspace. That is true. That is true. Because of the increased cardiac size, yes, they will take up the space and they will not let the lungs to expand. Okay. But it doesn't necessarily mean to say that it is silhouette, because silhouette is a comparison between the densities having equal densities, okay, which has equal densities. But lateral borders of the lungs generally are not seen. It is not visible. If they are not visible, yes, it is a normal X-ray. If they are visible, we are calling it as a visceral pleural line and calling it as a pneumothorax. Yes or no? Right? So that's the reason. Yes, logically you are correct. Logically you are correct. But still, since lungs do not have any kind of a density on an X-ray, so we need not really worry about this kind of simple thing. Get it? Aman, get it? Right. Okay. Okay. Let's continue. So this one is a lingular segment. You see here homogeneous density obscuring the left heart border. So it is lingular segment. Okay. So now let us recall back once all. It is an opaque. Okay. It is opaque than the surrounding lung. It is homogeneous. It is fluffy, indistinct, unmarginated, okay, and they abut the pleural surface, such as the interlobar fissure, which the case, the margins will be sharp. Interstitial pneumonias will generally cause the prominence of the interstitial tissues of the lung in the affected area, and the disease can spread to the alveoli and resemble an airspace disease. Okay, so these are the key signs of the pneumonia. Right. Pneumonia tends to be homogeneous in density. Lobar pneumonias may contain air bronchograms. Pneumonias may be associated with atelectasis in the affected portion of the lung. Okay. Now let's try to understand two different scenarios. We will try to understand what exactly is a lobar pneumonia, segmental pneumonia, and interstitial pneumonia as well. Okay. Let's try to see. Pneumonias may be distributed inside the lung. If it is happening, it can happen down in a single lobe. It can happen in a single segment. It can happen as interstitial. It can happen as round and cavitary. See, all of them are pneumonias together, but all of them are different patterns. Okay, if it can happen, if it is happening in a single lobe, we call it as a lobar pneumonia. If it is happening in a segment, we call it as segmental pneumonia, or technically speaking, we also call it as bronchopneumonia, involving a single bronchus in a single segment. Simple. Okay. It can be happening down as an interstitium where the inflammatory fluid or the excretory fluid gets settled down within the interstitium and contractively affecting the alveoli. So interstitial pneumonic pattern. Then it can be a rounded pneumonia and a cavitary pneumonia. We will see these are two different special entities. We'll talk about them, but try to understand these simple things first. Lobe, if it is getting down, involved within a lobe, right upper lobe, right middle lobe, right lower lobe, or left upper lobe, lingular lobe, or lingular segment, we generally call it as, or left lower lobe. So that can happen anywhere. Then segments, it can be diffuse, it can be localized, okay, it can be unilateral, it can be bilateral. Interstitial, yes, it can involve in a single lobe or a single segment. It can be unilateral, it can be bilateral. So n number of patterns can be seen here, okay, unilateral, bilateral, single segment, double segment. So many patterns are there, but still this is the main classical way that you should be able to recognize them. Lobar, segmental, interstitial, round, and cavitary are the key patterns of pneumonia, right? They describe the distribution of the disease inside the lung. So they are saying where exactly, which anatomical structure is involved, and they are not diagnostic of pneumonia because many other diseases can produce the same kind of pattern. For example, to say, in the yesterday's exam, we were showing, okay, there is a homogeneous density that is present down in the right upper lobe. The right upper lobe homogeneous density or something like old patchy like density that is seen in the right upper lobe also can happen because of the Gons focus granulomatous reaction as well. It can also happen with an atelectasis with an S shape and atelectasis of the right upper lobe, and if it is showing up as a homogeneous density, yes, it can happen as a result of bronchogenic carcinoma as well. We are calling it as golden sign of S. So if I'm talking about a homogeneous consolidations all over these places, because I'm talking about so many other diseases, right? I cannot technically define my patient with the radiographic density as a homogeneous thing, and I must be hinting it is a pneumonia but not a cancer. No, a radiologist will be failed if he does that. So what exactly happens? So if a radiologist is writing a lobar consolidation, a segmental consolidation, an interstitial pneumonic pattern, it doesn't necessarily mean to say that he is talking only about pneumonia. There should be some other secondary signs which also should be confirmed. So clinical correlation is always necessary in making a diagnosis of pneumonia. Pneumonia, as we learn to be, is a very simple condition, the common condition that presents down, and that is the first reason why a chest radiography is taken. Cough is the single symptom why a chest radiography is prescribed. So for a single problem like this, if we are making a wrong diagnosis, and see how complicated this diagnosis is, you should be able to differentiate well. So that's the reason, try to understand your radiographic report. Okay, you have to know what the radiologist is talking about. Radiologist has to obviously know what the other clinical physician wants to listen about, right? So both of them has to work hand in hand. Radiologist cannot ignore symptoms, and a clinical physician cannot ignore your classical radiographic reports. Okay, so both of them has to work in together. But generally in a clinical setup, this does not happen. Clinical clinical physician always writes the medicine what comes down first to his head. Radiologist always writes the report what comes down to his head. Okay, if I cannot look at the pattern as other radiologist, experienced radiologist looks like, I'm just writing my own report rather than creating the real disease and the real scenario. Yes, if I wanted to give a broad spectrum antibiotic, if I want to give a fluoroquinolone, but rather than giving fluoroquinolone, but I am so interested down in writing down the cephalosporins, I will obviously write cephalosporins, but I will ignore the fact that pneumonias are treated by fluoroquinolones. Did you understand what exactly happens in a clinical setup? So if you are trying to learn it in such kind of a way to work in association with your radiograph. Okay, always it is necessary to understand your radiological report. You should have a clear understanding what the report says. Okay, right. First, lobar pneumonia. Remember, any kind of a lobar pneumonia is generally prototypical, and it is very, very related down to pneumococcal pneumonia that is caused by streptococcus. Streptococcus bacteria are the most common type of bacteria that causes lobar pneumonias. Okay, we are calling it as lobar pneumonia, but still the patient will have the symptoms before the disease involving the entire lobe. So now you tell me, if you can remember the two clinical scenarios, which one of those patients will eventually develop the streptococcal pneumonia? Is it the 3-year-old male patient or is it 15-year-old female patient? Which one will develop the streptococcus pneumonia? Who are more likely to develop? If you can remember the two case scenarios I have told you before, likely to progress in the later stages as streptococcal lobar pneumonia. Why does Shubham think it is the 3-year-old male who will develop that one? Exactly, you are talking about the 15-year-old female. Okay, who in the two cases what we have discussed before, whom do you think that eventually will try to develop a lobar pneumonia? Who will develop? See, the PPT here, the slide here, what we are talking about says that, okay, even if it is called as a lobar pneumonia, the patients may not show up the radiographic pattern, or the patients may not develop the symptoms even before the disease involves the entire lobe. Before the disease pattern is going down and involving down in the complete and affecting the entire lobe, the patient should have already developed symptoms. So the two case scenarios about the 3-year-old male and the 15-year-old female, which we have talked, which one are more likely to develop a lobar pneumonic pattern if the X-ray is taken after few days? Did you understand my question now? Yes or no? Did you understand my question now, Aman? Reshma, did you understand my question now? Yes, yes. Okay, so answer it. Which one? Which one will develop lobar pneumonia in the later times? Which of those two cases what we have discussed before will develop the lobar pneumonia later on? It will be obviously the 15-year-old female. Now you get it? Did you understand? So as a doctor, what we did is that it is not only about finding. See, I never said pneumonia is going to affect mostly children. Okay, I never said it is not going to affect children. Both of them are child. Okay, my answer would be much more precise if I say it is an infant. Both of them are children, right? Okay, I did not particularly say it affects only in children. No, I said varicella pneumonias are particularly in children. Streptococcal pneumonia happens as most common. Did you get it? That's what I tell, I guess. Right? Okay. So it is obviously the 15-year-old female who is more likely to produce the symptoms later on. So such kind of assessing the progression of the disease even before the patterns are shown is always necessary in a patient of pneumonia, because pneumonia is the leading cause of death in a community. Remember, there is a high mortality rate in children with pneumonias. Do not ever ignore this clinical point. High mortality rate is present in people with pneumonia. Even now, the COVID virus is giving out an interstitial pneumonic pattern which has significant mortality rate and a progression, a very, very fast progression thing, right? Did you understand now why exactly I'm talking about? So even before the patient develops symptoms, a clinical physician should be able to estimate what is going to happen down in the future. Yes, COVID virus is a pattern of interstitial pneumonia. It progresses very rapidly and mortality rate is something around like 0.1 to 3%. Did you understand it? It is significantly a higher number. The progression happens because of the incubation period. Infection pathogen already started to enter down in the bronchus. It starts to produce an interpneumonic pattern within 15 days, and the patient will be infective for the next 21 days. And the patients who has developed an interpneumonic pattern will likely to produce and go down into a complete respiratory atelectasis or acute respiratory distress syndrome, which is the leading cause of death in COVID-19 patients. Did you understand now how which our information has helped here? Yes, you wanted to learn about COVID, and yes, COVID is an interstitial pneumonic pattern. It happens down as bronchodemonic changes in the first place, and later it spreads down into all over the area and comes down into the interstitium, causing complete atelectasis and causing severe dyspnea and severe acute respiratory distress, which is the leading cause of death in all COVID-19 patients. Yes, is this clear now? Right? Well, we will talk about that one, but still, did you understand what exactly, how the radiological report is helping the COVID-19 as well? Okay, so this is a mnemonic pattern. Okay, I will talk about that one, which is completely out of our scenario here. Okay, right. So now you see here, this is a peculiar finding here. You see here, I can see here fluffy, hazy densities that are distributed all over the upper lobe of the right lung. Okay, there are hazy homogeneous densities that are present in the upper lobe of the right lung. But if I look closer, you see here, this one is showing that it is a clear margin of the right minor fissure. Yes or no? So these fluffy densities, this homogeneous density did not extend beyond this fissure, which obviously means to say I am looking at a right upper lobar pneumococcal pneumonia, because lobar pneumonias are usually pneumococcus, right? So pneumococcus is the leading cause of community-acquired pneumonia, right? Okay, pneumococcus is generally a lobar pneumonia is generally present down in pneumococcus. So I am giving medicine redirected to pneumococcus. See, I think if you have completed your pharmacology, there are different medicines for gram-positive bacteria, gram-negative bacteria, right? Macrolides, sulfonamides, penicillins, fluoroquinolones, tetracyclines. So all of them are different medications redirected for different kinds of bacteria, right? One bacteria is much more sensitive for one antibiotic and other one is much more resistive for one antibiotic, right? That is what you learned in pharmacology. So that knowledge, you are applying it to your ideology here. So give the medicine such as fluoroquinolones to this patient rather than giving some other drug like erythromycin, which does not have any kind of sensitivity towards this patient. This patient will require a fluoroquinolone treatment along with a broad spectrum cephalosporins, but rather than going down to a simple drug like erythromycin. Yes, did you understand? It is entirely different. The treatment strategy, the whole drug has changed, the whole dosage has changed, right? You can also see in this patient, okay, you can also see in this patient that this one, the ascending aorta has also been abetted. So sign here, where the ascending aorta shadow and the superior vena cava shadow should have been present. Okay, that one is also been abetted. And also, so this one is the sign. So if the ascending aorta is not shown, which means to say the problem is present on the right upper lobe. So there is a sign as well. There is also a lobar involvement as well with a sharply defined minor fissure, right? Can you find there are two other findings in this X-ray? Can you tell me what are the two other findings? What are the two other findings in this X-ray here? There are two other findings in this patient. What angle? There are three angles. There are three or four angles. Okay, there is a presence of an endotracheal tube. Perfect. One thing. Okay, the bone above in the middle. Apex of the heart is close to lateral. So what does that mean, Nashra? Apex of the heart is close to lateral side. What does that mean, Nashra? Cardiophrenic angle is acute. Okay, what does that mean, Shubham? Yes, there are good findings, but what does that mean? Apex of the heart is close to the lateral, indicates that there is a cardiomegaly, left ventricular hypertrophy. And if you look possibility, this patient might be suffering with a congestive heart failure because this is gross cardiomegaly. It can be happening because of restrictive cardiomyopathy, most probably. Okay, this must be a patient of congestive heart failure. And you can also see that there is a tracheal deviation, but that is not a tracheal deviation to the right side because there is a rotation. See, yes, there is a endotracheal tube that is present, but I cannot see the tracheal shadow over the spinous processes. The spinous processes are here, but still it is actually happening because of the rotation, because you see here the medial clavicular ends are different. So it is a bedridden patient, which is an AP view. This is a most probably a congestive heart failure. So all these patients will eventually be called as lobar pneumonia, but this one you remember here, pneumococcal pneumonias are very common in nosocomial spreads. Any kind of a patient who is hospitalized, those patients are likely to develop pneumococcal pneumonia. Did you understand? Pneumonia is the most common cause of nosocomial pneumonias, and mortality rate is technically very high, right? Okay, right. All the lobes margins are well sharpenated, okay, indistinct and irregular margin. If there is no moat in the fissure, it is there indistinct and irregular margin. If it is within the fissures, yes, the margins are clear and sharp marginated, right? That's what the pattern of lobar pneumonia is. Lobar pneumonia, yes, they also have a sign, and yes, they have a sign when they come in contact with the diaphragm, heart, and aorta. Yes, that's what we actually saw it before. And they also almost contains air bronchograms if they involve with the central portions of the lung. Let us see in this patient. You see here, look closely. Yes, I can see a air bronchogram here. You see here, I am seeing at the apical bronchus here. See, right upper lobe has got apical bronchial segment, segmental bronchus, and then anterior segmental bronchus, and then the posterior segmental bronchus. And you can see here, I can see a tube-like structure, a radiolucent structure here. So this is the air bronchogram that is I'm looking at. Okay, so it will be generally almost present in most of the patients. Right. Okay. The right upper lobe. You look here. This is another patient. Let's complete the upper lobar pneumonia and then take a break. Okay. So now the right upper lobe ascending aorta. See this one is also in this patient. The ascending aortic shadow is completely abated. So it is silhouetted. So which obviously means to say I'm looking at the right upper lobar pneumonia. And this sharply homogeneous density did not extend beyond the minor fissure because I can see the fissural density as a sharp marginated curve. Right? So by this I came to understand that this is a right upper lobar pneumonia. Okay, which can also happen down as the streptococcal pneumonia as well. Okay, if it is in a hospitalized patient, it is pneumonia, pneumococcal. If it is in a community present patient, it should be streptococcal. Right? Okay, that's what the most important causes are. All right. So now try to continue. Okay. So this is the right upper lobe if it is silhouetting with the shadow of the ascending aorta. So we came to know it is the right upper lobar pneumonia. Right now, we are trying to deal about with trying the application of the silhouette sign. We have already seen this condition before. So if the right heart border is silhouetted by a homogeneous density. So it obviously indicates that the problem is indeed present in the right middle lobe, which is the anatomically related structure. We have already seen this condition before. You see here in this X-ray, I cannot see the right heart border, right, which is completely obscured by the shadow that is present down here in the right lower lung field. But since I am applying the silhouette sign as the right heart border is not clearly visible, and this one is not extending beyond the minor fissure, which obviously suggests me that I am looking at a right middle lobar pneumonia. Okay, so right middle lobar pneumonia, what is the silhouette sign tells me? Silhouette sign tells me that it is the right heart border that will be obscured. In the right upper lobe, it will be the ascending aorta, and in the right middle lobe, it will be the right heart border that will be obscured. All right, so that one. Then what about the right lower lobar pneumonia? Right lower lobar pneumonia, you see here, I can see the right heart border quite clear. And you can see here, I see a homogeneous hyperdensity with the hazy margins, okay, that is presented down in the periphery of the right lower lung field, okay. See, lung field is entirely different, okay. Right lung field is entirely different from the segmental divisions, okay. I can see a homogeneous density that is obscuring the shadow of the right hemidiaphragm, sparing the right heart border. The right heart border is quite clear, and the homogeneous density is present down in the periphery and obscuring the shadow of the right hemidiaphragm. So by this, I came to understand that it is a right lower lobar pneumonia. But how can I actually differentiate this one from the pleural effusion? Pleural effusion should have a meniscus sign, and it should be a fluid-based density, which will be much more higher density than this one. So pneumonia is generally a little lower density than the shadow of the heart and the diaphragm. So pleural effusion is much more higher and has got the equal density that is related down to the heart. And it has got a meniscus, and where the rib shadows are also clearly not seen, right? So that is pleural effusion, but this one is a lower lobar pneumonia, sparing of the right heart border, but obscuring the shadow of the right hemidiaphragm along with cardiophrenic rhesus obscuration is called as the right lower lobar pneumonia. All right. So now left upper lobar pneumonia, which obviously there will be the obscuration of the aortic knuckle. Okay, obscuration of the aortic knuckle, and obviously it will be involving down within the oblique fissure. Right, you see here oblique fissure. This is the right lung, left lung has got only oblique fissure, and you see here this one, this hazy density is not extending beyond the oblique fissure. And this is also obscuring, this hazy homogeneous density is obscuring the shadow of the aortic knob or the aortic knuckle. So that's how I came to understand that this is the left upper lobar pneumonia, right? And what about the lingular segment? Lingular segment pneumonia is generally obscuring the shadow of the left heart border. Okay, left heart border, left atrial shadow, and the left ventricular shadow will be completely obscured, which means to say, which will suggest me that the problem is present down in the lingular segment of the left lung. Okay, right? And the diaphragmatic shadow is spared. Diaphragmatic shadow is quite clear. But in the opposite way, if the left heart border is spared, you can see here, I can see the left heart border very clearly, but the left heavy diaphragmatic shadow is completely obscured. So which obviously means to say I am looking at a case of left lower lobar pneumonia. So this is how I am applying my Silotti sign to diagnose what kind of a lobar pneumonia I am looking at. Okay, so this is quite simple. Okay, do not forget about this sparing, which one of the organ that is spared or which one of the organ that is obscured or siloted. Okay, so it is quite easy. It is not difficult. Left upper lobar, okay. Left upper lobar has got only obscuration of the aortic knuckle. Okay, aortic knuckle. This is the aortic knob, and it is not extending beyond the oblique fissure. So I can see a homogeneous density that is obscuring the aortic knuckle shadow, right? And I can see some air bronchogram pattern here. You see air bronchogram pattern here, and it is not extending beyond the oblique fissure. So that's the reason it is the left upper lobe. Is this clear now? Yes, Reshma, is this clear now? Right. Okay. Now, so that is now what exactly is a segmental pneumonia? Segmental pneumonia is entirely different from the bronchopneumonia. So lobar pneumonia is pneumococcal pneumonia, and whereas bronchopneumonia is generally caused by the Staphylococcus aureus. So many gram-negative bacteria such as Pseudomonas aeruginosa can also produce the same picture. Okay, so let us see bronchopneumonia patterns. And you see here the difference between a lobar pneumonia and a segmental pneumonia is that they will have many foci, okay, in the lung at the same time, and therefore it is frequently involving several segments of the lung simultaneously. So it is a diffuse reaction, whereas lobar pneumonia is a localized reaction, bronchopneumonia is a diffuse reaction, right? And then the margins of the segmental pneumonia tend to be fluffy and indistinct as well. Okay, so they are not bound to the fissures since so many segments are present. Either it can be present also in the apico-posterior segment, also along the superior and inferior lingular segments as well. So if it is happening, I can see the extension of these fluffy hazy shadows beyond the fissures. So they will be obscuring, or these shadows will be siloting the fissural shadows. So that's the reason it is called as a segmental pneumonia and a bronchopneumonia. And generally, since the bronchuses are the ones that are starting from the hilum, all the densities I will be looking are redirected and closely present near the hilum itself. So we call them as perihilar densities. Okay. So unlike lobar pneumonia, segmental pneumonia produces an exudate that fills up the bronchi. So generally the air bronchograms are not present. So here the bronchuses are completely filled, and in some cases, yes, there will be volume loss, which means to say most of the patients will eventually present up with respiratory distress. All right. So now you look here, there are multiple irregularly marginated or poorly marginated patches of airspace in both the lungs of the individual. You see here perihilar, hazy, patchy opacities that are seen in the particularly lower lobes of the lungs, right? Okay. And the same thing, you generally, you need not technically apply the Silotti sign here, but you can see them as a diffuse reaction present bilaterally, Even yes, sometimes you can understand which are the segments are involved, but it is not necessary. When you are seeing it as bilateral, you may not technically apply the severity side. You can actually see the severity of the disease, which is different from here. See, upper lobe is involved, lingular segment is involved here, lingular segment is involved, lower lobe is involved here, middle lobe is involved, right? And also the lateral segment is involved, lower lobes are involved. So not only one particular segment is involved, but more segments are involved. So such kind of a mnemonic pattern is called as a broncho pneumonia. Yes, of course, it's crossing up the horizontal fissure. You see here, this one almost, right? So now this kind of pneumonia is technically called as a staphylococcal bronchopneumonia. So this is a characteristic distribution. How do you actually define it? Okay, perihilar hazy densities. Okay, we define them as perihilar hazy densities, right? Generally, no, there is no described atelectasis. Which shadow are you talking about, Hisham? Where exactly? So are you talking about these lines? Are you talking about these lines? So that's the reason you are talking that there is described atelectasis. Is that so, Hisham? Where is the fissure here? No, there is no discoid atelectasis in this patient. Not exactly. Where can you see the fissure? Where is the fissures prominent? Where did you see the fissures are prominent? No, that is the stomach shadow, okay? That is the one that Shafiq is pointing out is the, no, it's not the fissures. It is the stomach shadow. No. It is the stomach shadow, okay? It is the antrum of the stomach, okay? Right? Well, you are ignoring one thing here. You are ignoring to check out the quality of the radiograph. This is a poorly expiration. Okay, the poor inspiration. This is an expiratory film. In an expiratory film, yes, the heart may look like as if there is a cardiomegaly. Yes or no? Count the ribs. How many ribs are visible? 1, 2, 3, 4, 5, 6, 7. See, 10 posterior ribs should be visible to say that there is a good inspiratory capacity. Yes or no? Right? So this is an expiratory film. So that, no, it's not any regular heart size. Get it, Nitish? Right, okay. So the same thing you see here. So you can also call this one as centrifugal distribution. So understand. So this is how a lordotic view looks like. No, lordotic view does not look like this. Lordotic view is made for only apex. Okay, I think mostly the patient is actually made down to lie in a supine position. Okay, I think that's the reason it could have been happening like this one. Okay, the clavicle is above the lungs. Yes, obviously that's true. Right. Okay, let's not get beyond our points. Okay, you see here, and this one you have to understand one thing, that the lobar pneumonia is almost a single lobe, where the bronchopneumonia is different segments. And the other thing, since it actually follows the distribution of the bronchial tree, so it happens from center to periphery. Okay, right? But the spreading of the disease happens from periphery to either superior regions or the inferior regions. Okay, that is how the disease spreads once it has occurred. But first, how it starts from the center to the periphery. So that's the reason we call it as a centrifugal distribution via the tracheobronchial tree. Okay, so many focus centrifugally distributed perihilar hazy densities or perihilar hazy opacities or patches that are seen around the hilum is the way how a radiologist describes this bronchopneumonia. All right. Okay. Now, since the lung segments are not bound by the fissures, the margins of segmental pneumonia generally tend to be fluffy and indistinct. Yes, usually there are no air bronchograms that is present. Okay. But if sometimes inflammatory exudates fills up the bronchus and the air spaces around them, that's the reason there is no air bronchograms present. Okay, right. Now let us try to look at a very typical pattern which is called as interstitial pneumonia. Right. Interstitial pneumonias are generally are a characteristic features of fungal pneumonias and or pneumonias. Okay. The interstitium collapse will be there. The interstitium involvement will be higher, and all such kind of diseases we can actually pinpoint out to say that this kind of interstitial pneumonia pattern is indeed a viral pneumonia. So since COVID-19 is very famous, yes, obviously one is showing a pattern of interstitial pneumonia. Mycoplasma pneumoniae, pneumocystis carni are generally are the most common type of most common type of lung infections that are seen in a patient with MS. Okay. Remember, this is a very high yield point. Mycoplasma pneumonia and pneumocystis carni pneumonia are most common in patients with acquired immunodeficiency syndrome or the AIDS. Hospitalized patient, okay, hospitalized patient with a history of AIDS and HIV, okay, human immunodeficiency virus or acute acquired immunodeficiency syndrome, AIDS. What is the most common type of infection? Mycoplasma and pneumocystis carni or pneumocystis pneumonia is the one that is most common. Yes, it shows up a pattern of interstitial pneumonia. How actually interstitial pneumonia happens is the interstitial pneumonia tends to involve the airway walls and the alveolar septum, and they produce, especially early in its course, as a fine reticular pattern in the lungs. Okay, remember this is a very very characteristic feature. Reticulonodular pattern is generally fibroproliferative diseases, okay, where the granulomatous reactions happen, but interstitial pneumonia do not have a granulomatous reaction, so that's the reason they show only reticular pattern. Okay, nodular pattern and reticulonodular pattern are entirely related down to a fibroproliferative diseases like tuberculosis, sarcoidosis, etc. But this one, interstitial pneumonia, in particularly shows down the reticular pattern, and it will be fine reticular pattern. Okay, we will see what is fine and coarse, but fine reticular pattern is a characteristic feature of interstitial pneumonia, and they spread to the adjacent alveoli. Okay, they spread to the surrounding alveoli and produce a patchy or confluent of airspace disease. Confluence to say means to say group. So groups of patches are seen in the segments, and there will be also the interstitium that is present that is closer to it will show up a reticular pattern. So that is a typical presentation of most viral pneumonias. Okay. So original interstitial nature of the pneumonia is impossible to recognize radiographically. But what happens is that because of these patches, that's the reason the interstitial nature which can be observed cannot be observed in these patients, so which became a very characteristic feature. So that is what a fine reticular pattern is. Let's try to observe the picture. You can understand. You can see here there are bilaterally centrally located interstitial hazy densities and see the fine reticular pattern of the interstitium here, right? You see here there is a patch, big patch like density, which is spread bilaterally and happening from the center to the periphery, right? Okay, and there is also a presence of a fine reticular pattern, which is not thick. Okay, coarse reticular pattern will look much more whiter than this, but this is a fine reticular pattern. Okay, so by this, unless I have a history that the patient has got AIDS, I will be generally mistaking this one for a chronic fibrotic disease such as sarcoidosis. But you see here, the difference here is that you always have to know if there is a lymphadenopathy. Okay, what is the diagnosis for sarcoidosis? There will be bilateral hilar lymphadenopathy with a right paratracheal lymphadenopathy along with a reticulonodular pattern. That is the stage 2 sarcoidosis, right? So since we are not able to find out the lymph nodes, if they are not adenosed, if they are not extended beyond 1.5 centimeters on a radiograph, we cannot generally see the lymph nodes. So that's the reason sometimes these cases with a viral pneumonia or any kind of this pneumocystis corneae like infections will generally, maybe misdiagnosed as a condition as diseases like sarcoidosis. But this problem can be rectified through experience and practice. Okay, more getting down into the more peculiar details, because they have more peculiar sarcoidosis has got more peculiar findings like reticulonodular pattern with bilateral hilar lymphadenopathy with right paratracheal lymphadenopathy. Yes, I will be able to differentiate that patient as stage 2 sarcoidosis, right? But if it could have been a stage 1 sarcoidosis, it will be just only fine reticular pattern, right? So that's the reason I have to clinically correlate it with these symptoms. Okay, sarcoidosis is it is a cell-mediated immunity reaction, whereas AIDS is entirely different from it, right? So the symptoms of AIDS are entirely different from the presentation of the sarcoidosis patient as well. So that's the reason symptoms have to be correlated to make out a diagnosis when it is, uh, you know, hindering with other diagnosis as well. So you can make out the best diagnosis only through experience and more observation. That's okay. Then you see here in this patient, generally in a sarcoidosis patient, there will be pleural effusions and there will be nodular patterns. But you see here, this patient do not have any kind of pleural effusions, and there is no hilar adenopathy. So that's the reason how I was able to completely rule out sarcoidosis and name it as a pneumocystic carni pneumonia, okay, which is actually called as PCP, which is common in patients with AIDS, right? So no hilar lymphadenopathy, no pleural effusion tells me that this patient is not sarcoidosis, but obviously the fine reticular pattern is present as a pneumocystic carni infection. So that's how I came to my a conclusive diagnosis. Okay. Now we are going to look at a very severe type of pneumonia, which is called as cavitary pneumonia. Okay. So cavitary pneumonia, generally any kind of an organism that causes a cacheating necrotic lesion, which will eventually dig down and completely destroy the alveoli and interstitium around them, which will form a space or a cavity, is called as a cavitary pneumonia, or we also call it as cavitating pneumonia, which is commonly seen in Mycobacterium tuberculosis, right? Cavitation is the most common problem in the post-primary tuberculosis, which also happens because of reactivation tuberculosis, but rare in primary TB, right? See, last time when we were trying to learn about the TB clinical physiology, when we are trying to learn about this pathophysiological mechanisms, I told that it starts as a granulomatous reaction first, but later on it starts at activating the caseous necrosis reactions and finally producing a cavity, right? So Ghon's focus is not a cavity. Ghon's focus is a hazy density, where the granulomatous reaction, it is suggesting the granulomatous reaction. The next immediate any kind of granulomatous reaction will eventually have to heal. And how does that heal? It heals down by calcification or fibrosis. Okay, if it is healing by calcification, yes, a calcified Ghon's focus along with a calcification of ipsilateral hilar lymph node is called as a primary complex, right? But Eventually, even that one also has been gone, that stage has also been gone, and then later it produces the caseating necrotic reaction in the body, and eventually what happens is that it starts to digest. Mycobacterium tuberculosis starts to digest the interstitium around them and also completely destroys the alveoli, which will form an empty space, which is clinically called as a cavitation, right? Cavitations are most common in post-primary tuberculosis, and it is obviously filling up the it is obviously filling up the air spaces. It is obviously involving the interstitium and there is destruction. Yes, involvement of bronchi is also there. So that's the reason we are calling it as pneumonia. So you understand here, when a doctor, when a radiologist is writing, I can see a cavitary pneumonic pattern. He is obviously talking about tuberculosis. He is not talking about pneumonia as a disease here. He is talking pneumonia as a radiographic appearance here. Did you understand what exactly the report is talking about? There is a difference. You might be seeing down pneumonia as a disease in clinical scenarios. One, in a radiological setup, pneumonia is a pattern. Pneumonia is a radiographic finding, okay, which obviously tells you about the progression or the inclination of the disease, okay. It talks about the clinical scenario or the exact clinical condition of that patient you are observing. So do not confuse yourself with these terms. Did you understand where the confusion comes over? Please respond, guys. Others, what about others? Yes, no, right? Okay. Okay, so let us try to look at the cavity. Last time I remember some student was asking, sir, why does a cavity has a thin wall and how can I differentiate it from the abscess? I guess it should be mostly Shafiq or Hisham. I don't exactly remember. I think, yes, somebody was asking me, why does a cavity have a thin wall and how can I actually differentiate it from a abscess, right? Right? Yeah, exactly. So let us try to deal about that question here. We will try to understand what is that. Okay, the cavities are generally located down in the upper lobes, first thing, generally bilateral, a thin walled, and have a smooth inner margin, and they do not have an air fluid level. So generally it is a caseating necrotic reaction. Okay, it still did not enter the next stage as liquefactive necrosis. Okay, caseating necrosis is pus and liquefactive necrosis is entirely filled up with blood. Okay, and granulomatous reaction is just a granulomatous or fibrosis condition where the calcification should be seen. Okay, so a cavity will generally have no capsule, where an abscess will have a capsule. Okay, a capsule is generally a healed up cavity. Okay, an abscess is generally a healed up cavity. So that's the reason cavity has got a thin wall and has got a smooth inner margin. Whereas an abscess will not have a smooth inner margin, it will have a thick wall along with the irregular inner margin, and it contains air fluid level. Whereas the cavity has a thin wall and a smooth inner margin and contain no air fluid level because it has not started liquefactive necrosis yet. After liquefactive necrosis, apoptosis happens and the whole area is destroyed, right? So that's how I am differentiating it. So which means to say I am talking about the progression. So from granulomatous reaction, like a Gons focus to calcification, and then calcification to cavity, and cavity to abscess. That is how the pattern is going on. So what are the complications of tuberculosis? Cavities, pleural effusions, uh, fibrosis, pneumothorax, or the complications of tuberculosis. Now, is this clear? Right? Yes, a healed wall cavity is a fibrous wall cavity. Yes, almost. Yes, you can understand it that way. Yes. Right? So what are the complications of tuberculosis? Complications of tuberculosis are generally cavities, pleural effusions, fibrosis, pneumothorax, traction bronchiectasis, bronchostenosis, fibroproliferative conditions. All of them are the complications of your tuberculosis. So if you have understood the tuberculosis chapter well, I guess you will be able to answer down your uh, fill in the blanks as well. But I guess most of the people did not do it yet, but still I'm helping you right now. So if you are clever enough, see what you are writing down there. Okay. So, and transbronchial spread is also happening. It happens from one upper lobe to the opposite lower lobe or another lobe in the lung. So, which you should say that this kind of a pattern is generally happen in case of tuberculosis mycobacterium. And you also have to understand if it has to form a cavity, hematogenous spread should be involved. And if you are suspecting a patient with a hematogenous spread, extrapulmonary tuberculosis manifestation should also be suspected. So obviously means to say, if I am looking at a cavitary pneumonia, I am obviously looking for and treating for his systemic illness as well. Did you understand? The cavitary pneumonia findings suggest to me that I should be not ignoring the extrapulmonary manifestations, and I should be also aware that it is more likely to spread and progress and completely destroy the entire lung. So how am I going to prevent it? I am going to prevent it with a stringent anti-tubercular therapy, right? Did you understand? So let us say, for example, let us take a case condition. A condition something like, let us say, a 35-year-old male with a known history of tuberculosis has come down to your hospital with a high-grade fever, right? And right now he has complaining of chest pain with a productive sputum, okay, and a mild grade hemoptysis. Yes, which obviously lets me think, okay, if I should be suspecting down a cavitation or an abscess, right? Then I took an X-ray and I came to find out that there is a cavitary pneumonia. Right now, what I actually do to this patient is that, okay, before when he came to me, I suggested him to take anti-tubercular medication for only 1 month. But right now, since he has progressed and there was a reactivation of this TB, right now the physician obviously has to write down a complete anti-tubercular therapy with dots. Dots means to say directly observed treatment strategy. There should be a strict observation of medication being taken in front of the doctor or a nurse. That is called as dots. Dots therapy, directly observed treatment strategy. Now I prescribe dots of anti-tubercular therapy to this patient at least for 6 months, where my prescription said before for only 3 months, and I was thinking that it will not reactivate. But right now, I am, after the second admission, after the second radiograph, I changed my complete protocol where I asked the patient to take it home. Right now, I am asking the patient to take it in the hospital itself, right? So that is called as DOTS therapy. Dots generally in India and African countries will be done by a health assistant. Okay. Tuberculosis patient has to go to the hospital every day and take the medicine in front of the doctor or in front of the nurse. You will be given down a pack of 365 medicines in it. Okay. One tablet a day. Let's say it like that. Okay. Every day from day 1 to day 365, you will be given down as numbers. Every day you are taking that medication and you are signing it. So which obviously is giving down me the better treatment strategy in the prevention of the complications and reducing the mortality rate related to Mycobacterium tuberculosis. Did you understand? A radiographic finding like cavitary pneumonia has entirely changed my treatment protocol. Did you understand how radiography is influencing a general physician's work? Yes or no, guys? Do not ignore tuberculosis as a simple condition. Tuberculosis is a mortality, the mortality rates are technically high, and it is still vastly prevalent. Yes or no? Did you guys understand? Please let me know, right? Okay. So cavitary pneumonia suggests, how can I observe a cavity? Thin walled, smooth in the margin, and no air fluid level, right? Okay. So let us look at a condition here. Now, if this Sandra, Raymond, and other guys, if they are present here, okay, can you guys tell me what is this you are looking at? Which lobes of the lungs are you looking at? Okay, everybody tell me which lobes of the lungs are involved here. Which segments are we looking at? Which level of the CT are we looking at? Yes, we are looking at the inferior. We are looking at the inferior parts of the upper lobes, and also we are looking at the medial segment of the middle lobe, right? Okay, since it is just at the level of the carinal angle. You can see here, there is a lot of interstitial densities, but in between, I can see a hyperlucent or a radiolucent area with a clear margin. So this one has to suggest me that I am looking at a patient of cavitary pneumonia, which obviously I am looking at a tuberculosis patient. And you can also see here, there are multiple hyperlucencies that are spread all over the lungs, okay, in the right upper lobes. So cavitation. So you see here, first I came to find out the Gons focus. Now what happens, let us say the Gons focus happens in the posterior segment here, you see here, and this Gons focus eventually became down a cavity. Then it had spread to the adjacent area, this became again another cavity. This will start producing another Gons focus, and then the cavity happens. Then it went down to the other lobe, then there is a Gons focus here, and then it eventually progressed down into a cavity. So that is how tuberculosis is spreading from one place to another place. So multiple hyperlucent areas that are spread in the upper lobes are generally suggesting me a cavitary pneumonia. The diagnosis will be Mycobacterium tuberculosis, which is grade 2 or post-primary tuberculosis. Did you understand? So that's depending on the radiographic observations. I was able to also diagnose the progression. I was also obviously diagnosing the clinical scenario of this particular individual. So individualized observations can be made through radiographs. In a clinical scenario, sometimes the symptoms may be present, the symptoms may not be present, but radiographs will obviously show some kind of an evidence. Okay. No, you see here. Okay, the first thing is that we know as a fact that a Gons focus appears in the upper lobes. Yes or no? First thing, right? A Gons focus, a lesion happens in the upper lobe. Then, after the Gons focus starts to heal, it will either become fibrosed or either it will become calcified. But let us say that is only because of a single exposure to tuberculosis. But let us say the patient has got continuous exposure to the tuberculous bacilli. What happens? The reaction, the granulomatous reaction aggravates. And as the granulomatous reaction aggravates, what happens is that the Gons focus, whatever that is present here, the surrounding interstitium gets collapsed, the alveoli gets destroyed, and it eventually forms a cavity. So from the bacteria from here spreads down to here. And this one will form another Gons focus and eventually forms a cavitary over time. That's the same way, since it is connected down with the blood vessels. So that's the reason it will start going from right lung to the left lung. Okay. Or anyway, you can think of pattern. It started from here and went down to here or here. It is hard to tell it. Okay. Unless there are much more clinical evidences. Okay. Generally, it will be present down in the apico-posterior segments of the right upper lobes, or generally upper lobes, apico-posterior segments of the upper lobes. Okay, bilateral. It is Right now, right side is completely gone, okay? But so let us say if this is the apico-posterior segment, so what happened is that, okay, let us say the Gons focus started here and then went down to here and then eventually spread down like this. So is this clear now, Ravendra? Is this clear now? Okay, first a Gons focus is seen, then it might be calcified, or it will eventually, because of the reactivation or overexposure to the bacillus, it will start to form up destruction of the alveoli and complete destruction or the compression of the interstitium, which will eventually form down a cavity. So it will be spreading from one place to another place, and that is how the disease is progressing. So by this radiograph, I am making out an individual decision rather than completely depending on his presenting symptoms. I guess most probably this kind of a patient has got smaller cavities, so he will be having intermittent hemoptysis and having persistent chest pains and respiratory distress. Okay, and suddenly he will have high grade fevers, so acute high grade fevers with intermittent to say, uh, not continuous, okay, intermittent hemoptysis, vomit, coughing of the blood, along with persistent, which means to say continuous respiratory distress and chest pain. So by just looking at the radiograph, we will be also be able to think of his clinical condition as well. So that's how radiology is providing you a very detailed study. Since this is a CT, yes, more particular details, such things can be evaluated. So a doctor looks at the radiograph and says that, okay, have you been having hemoptysis? Yes, the patient maybe forgot to tell about the hemoptysis condition before, but right now comes up with hemoptysis. Did you understand? How are you also covering up your clinical history as well? Let us say you forgot to ask about hemoptysis, but immediately after looking at the radiograph, you are suspecting the patient needs a treatment with hemoptysis. Because I tell you, a clinical scenario in my own clinical experience, this is how it happened to me. See, I had a patient of a 47-year-old male who come up with a hemoptysis, okay, mild grade hemoptysis. He has saying that there is a lot of blood in the sputum. We can call it as blood tinged sputum, okay, blood tinged sputum, blood tinged sputum, right? Blood tinged sputum. So what obviously I asked the patient is that, okay, have you, he said of the blood tinged sputum. Then obviously I was thinking about a cavitary pneumonia and I took an x-ray. Then what happened is that, okay, right now, actually when a patient is talking about the hemoptysis or other condition, I will be thinking about lung cancer and other clinical scenarios. Right now, do I have to control his hemoptysis by giving antithrombolytic medications? Okay, fibrinolytics. Do I have to, since there will be a lot of thrombus formation and there is a problem of embolism, do I have to give blood thinners to this patient because he is coughing up of blood? Or do I have to, since there is a thrombus that is coming down, do I have to give blood thinners in this patient? Or since there is blood inside the sputum, do I have to give the fibrinolytics or completely reduce the bleeding? Or do I have to think about tuberculosis treatment? Which should I be talking about? See, you must, blood inside a sputum, blood inside a vomiting generally indicates that there is a hemorrhage going on in some place, which obviously suggests me that I have to, if I'm not thinking deep enough, it obviously suggests me that I have to stop the bleeding somewhere, right? That's the first thing that comes down to your mind. But when after close observation, what I actually came to understand is that yes, this blood tinged sputum is obviously coming down from the lungs, which obviously should not be controlled. What should be controlled? The cavitation has to be controlled. The granulomatous reaction has to be controlled. The inflammatory reaction has to be controlled. And how can I make it controlled? I will be controlling it by steroids. Did you get it? I will be giving out hydrocortisone, I will be giving prednisolone to that patient, and I will be giving out more stringent anti-tubercular therapy. And yes, cavitations generally happen in resistant type of tuberculosis. So that's the reason I have started a prescription of levofloxacin to that patient. Levofloxacin for 15 days and broad spectrum antibiotics like fluoroquinolones. I have given fluoroquinolones for him. I have given levofloxacin. Levofloxacin is a fluoroquinolone. So I have obviously treated the patient first to the main causative condition, but rather than giving out a treatment to the presenting symptom. Is this clear now? How did my radiograph help me to design my treatment protocol, right? So this kind of clinical conditions will be happening. So generally try to understand the pathophysiological mechanism, try to associate it with the radiographic findings, then correlate it with the clinical history, then look for the presenting symptoms, severe symptoms, non-severe symptoms, and then treat them accordingly. If I have treated the patient with a drug like tranexamic acid, if I have treated a patient with an NSAIDs, which will eventually control the bleeding, obviously I am pushing the patient to pulmonary embolism. Yes, pulmonary embolism will happen, which will eventually stop the bleeding, but I will be getting a more thrombus from that patient because that thrombus will be so big, and eventually that thrombus will get dislodged into the pulmonary artery where the patient will die within hours. So do not prescribe such kind of a medication unless you understand the clinical condition. Yes, bleeding in a cuff, yes, obviously tells me blood in sputum obviously tells me it is bleeding in the lungs, right? Hematemesis tells me if there is a bleeding in the stomach or esophagus, right? Sorry, in the esophagus particularly. I should be talking about portal hypertension, and I should be talking about esophageal varices or esophageal webs, right? Or blood in melena, okay, melena, blood in the feces will obviously tell me I am dealing with a patient of peptic ulcer. Obviously I will not be giving out control the bleeding. How I am going to control the bleeding? I am going to either control the bleeding with upper GI endoscopy, or in this tuberculosis patient I am going to do a bronchoscopy. But if bronchoscopy is not available, first I am going to manage his clinical condition and finally refer the patient to the bigger setup where the bronchoscopy has to be done, or complete lobectomy has to be done, or removing the cavity, excision of the cavity should be done, right? But generally in tuberculosis patient, we don't remove the cavities. If we are removing the cavities, there will be more exposure of bacteria from the cavity and more autocoid infection is going to happen. Okay, so do not control the cavity by excising it. You will expose more bacteria. Abscess has to be drained, but abscess cavities inside the lungs should not be touched. They should be treated with broad spectrum IV antibiotics. Okay, right? So my treatment protocol was justified and accurate, so to prevent, not only to prevent the complications, but also to save the patient. Okay, but eventually the patient died. That was a bad news though, but that came out of my own experience, right? Okay, let's complete off this chapter. This is cavities. Okay, cavities are very easy to understand right now. Now we are going to look at a very peculiar situation. Try to understand. When we were trying to deal about normal pulmonary anatomy, I posed a question: what is the normal level of the foreign body dislodgement? Yes, we will discuss that answer as it will be in the nasal conchae, and it will be the right upper main bronchus, or it will be the trachea. If it is in the, that answer is correct if it is happening down in the upper respiratory tract. Okay, the answer is correct. Dislodgement of a foreign body frequently happens in the nasal conchae and the trachea and the right main bronchus, which if it is talking about the upper respiratory tract. But lower respiratory tract is that the branches that are being produced after the main bronchus. The right main bronchus is divided down into the right upper lobar, middle lobar, and lower lobar bronchuses, and that one is called as the lower respiratory tract. So any kind of a foreign body entering down into the tracheobronchial tree, lower respiratory tract, is called as aspiration. Do not ignore this clinical condition. It is a very, very important clinical condition where spontaneous death can happen in these patients. Okay. And who are the risk patients? Okay. A lower respiratory tract foreign body dislodgement can happen in the lower lobes. Remember, but in upper lobes, it will be happening down in the nasal concave or the trachea or the right main bronchus. Is this clear? Is this confusion? Is there any confusion here? Yes or no, guys? Upper respiratory tract, nasal concave terminates, and the trachea along with right main bronchus, right? The final destination is the right main bronchus in the upper respiratory tract. But later on, if it is talking about the lower respiratory tract, I will be talking about the tracheobronchial tree and the segmental level or the lobar level bronchioles, which will be happening, aspiration will be happening more in the lower lobes. And who are the patients at risk? The patients at risk are the patients with stroke, the patients with traumatic brain injury, the patients with, yes, no, children generally are not, okay? Children are generally at risk if it is, a seizure children, okay? Any seizure is there, but generally it happens in children. Yes, that's true. But infants are the one that are more frequent in upper respiratory tract foreign body infection, where children, okay, uh, school-going children and comatose patients are generally, yes, no gag reflex, anesthesia patients, we will talk about this one. And drug overdose, what kind of drugs will eventually cause out this one? Respiratory depression, what are the drugs that actually cause respiratory depression? If you have learned it in pharmacology, tell me what are the drugs that causes respiratory depression? What are the drugs that causes beta agonists? Which beta agonists? Name them. Okay, fine. Let me answer that question for you. Opioids, neural stimulants, okay, opioids, SSRIs. SSRIs is serotonin reuptake inhibitors. Opioids like cocaine, right? And let us say central neurostimulants like SSRIs, antidepressants, and especially alcohol, heroin, drugs, okay, drug abuse. All these patients will have respiratory depression, okay, right? And a patient with a gastric esophageal reflux. Gastric esophageal reflux is a very, very peculiar clinical condition, which is also known as heartburn, which also presents up with respiratory distress and cough. Okay, because of the aspiration, re-aspiration of the fluid contents down into the esophagus, into the trachea. Okay, that is how it happens in the gastric esophageal reflux disease. And then post-operative effects from the head and neck surgeries. Any kind of a patient with encephalopathies, okay, hepatic encephalopathy, or any kind of a patient with cerebral tumors, or any kind of a patient has got cerebral edema or has internal hemorrhages, all these patients will have also the will have to undergo a head and neck surgery. So that's the reason those patients will be under the influence of morphine, and those patients will generally will have a condition called as aspiration. Okay, from my clinical experience, I will tell you a case. Okay, a male of 62-year-old. Okay, a male of 62-year-old has been coughing severely. Okay, a male of 62-year-old has been coughing severely as I sit in front of him while he was eating food. What should I be suspecting? A 62-year-old male is coughing up severely, started immediately just now. What should I be suspecting? He was also complaining of chest pain. Yes, of course, it is aspiration. But what I am looking for, which aspiration? Is it because of gastric esophageal reflex, or is it inflammatory fluid, or what? What should I be looking at in this patient? What am I suspecting? If I take a radiograph, exactly, you see here, his food went into the windpipe, exciting the reflex, right? So food bolus entry, food particles entering down inside the trachea will eventually cause this kind of a condition. Yes, no, chest pain will come eventually because of the respiratory distress. Okay, the bronchuses are severely being closed. So that's the reason atelectasis is happening, and that will be pursued as a, a chest pain. Okay, Reshma, right? No, they will not have from before. Okay, they will have eventually, they will start now. Okay, that's the reason I was saying that he developed the chest pain spontaneously, but not before. He was also complaining of chest pain. So I cannot misdiagnose this patient as an angina pectoris, but I have to think about tracheal aspiration of the food bolus. Did you get it? The treatment is entirely different from both of these patients. Yes or no? For cardiovascular disease condition, and if I'm complaining, if I'm thinking about myocardial infarction, I will be starting about aspirin and beta blockers, and I am also giving out nitroglycerin or digoxin like drugs, right? Sorry, digitalis like drugs. But which obviously, if I'm giving digitalis kind of drug, or if I'm giving aspirin in this patient, I am pushing and I am killing the patient more. So what is exactly, how can I find this patient? What will be happening? I will be finding out a typical sound called as tracheobronchial respiration sounds. I am hearing tracheobronchial respiration sounds, which sounds as wheeze, where the patient will be having a you know, whistling like sound while he is expiring. While he is inspiring. Since the bronchuses are completely compromised with mucus, or completely compromised with a foreign body, so he will be starting producing a sound called as wheeze, and also producing tracheobronchial respiration, because he started to use his accessory muscles of respiration. So I am going to perform a clinical maneuver called as a Hellmich Maneuver in this patient, which is, I think we also talked about this one last time. Hellmich Maneuver, we call this one as, which is a clinical part of CPR. Okay, which is a part of CPR, right? Okay, we will be talking about CPR in anesthesia and other conditions, but first let us try to observe the what are the radiographic features. Aspiration actually almost occurs in the dependent portion of the lungs. Dependent portion of the lungs are generally the lower lobes of the lungs. Okay, when a person is upright, the most dependent portion of the lung will be the lower lobes. Then the right side is more affected than the left, because the right main bronchus is more vertical and more wider in nature. Okay, so the right side is more vertical, more straight, and more wider uh, than the left main bronchus. So that's the reason the food particle could have entered into that patient into his right lung. Right lung, and has been dislodged down most probably into the lower lobes. Okay, and now, when a person is recumbent means to say lying down on your face, aspiration usually occurs in the superior segments of the lower lobes or the patient posterior segments on the upper lobes. Okay, recumbent in the sense either you are lying down supine position in 45 degrees or completely present as the completely lying down on your face. Okay, right. Acute aspiration will produce the radiographic findings of an airspace disease. See, since it is obviously the airspace is being compromised with an entry of a foreign particle, here sometimes with mucus plugs and food particles or any kind of a fluid. So what actually happens, there will be blocking the bronchus. So airspace is disease will be shown up here. So what actually happens, its location is rapidity dip appears, the group of the patients predisposed to aspirate are the clues to its cause. So severely spontaneously developing symptoms should tell me about the clinical condition of the patient. Okay, so I'm going to obviously look at down the history. I know I am looking at a patient with a condition of hemiplegia, and right now I have got the same patient's chest CT. What should I be thinking? What is the doctor thinking about? The doctor is thinking if he has any kind of aspiration or not, because the patient is complaining of respiratory distress. Obviously, the hemiplegia has got technically nothing to do with his respiration. Obviously, hemiplegia has got something to do with his motor cortex and basal ganglia, where it should be cerebral infarction, right? Or it should be some kind of a bleeding intracranial hemorrhage. Then I must be thinking, as a simple doctor, I should be thinking, man, the problem is inside the head, and why did this doctor prescribe a chest radiograph, or why did he prescribe a chest CT? That question should be solved just by thinking deeply that this patient will have poor respiratory capacity. He will have a poor respiratory effort, which is putting him under a risk of aspiration. So the doctor is trying to look at his aspiration and respiratory condition by taking down a chest CT. Did you understand? Do not actually, you see here, I think you might be hearing in stories. Okay, I went to a doctor, I was complaining of headache, the doctor prescribed me an abdominal radiograph. Or you must be hearing a story, okay, my patient had a uh, paralysis stroke, I have had a myocardial infarction stroke, and the doctor took down a brain CT. Man, are these doctors all mad? Obviously no. They are looking for the post coming complications, right? Later on, what are the patients going to develop? So aspiration is such kind of a condition that you have to analyze beforehand. And where do you get those clues? You will be getting those clues from the predisposed conditions. Okay, so look at the predisposed condition, look at the clinical history carefully, and you will be knowing it is happening because of aspiration. Get it? Right. Now, how does the X-ray look like? The X-ray looks like, you see here, I am particularly looking at the right carinal angle level here, almost, okay, just a little below the carinal angle level. But tell me, where am I looking at? Is this lower lobes I'm looking at? Are you sure? Is this lower lobes I'm looking at? Is this the lower lobes I'm looking at? These black arrows? Are these lower lobes? How many cannot understand that these are lower lobes I'm looking at? Is there any person who did not understand that it is present down in the lower lobe? Is still somebody thinking down it is present down in the upper lobe? Or somebody thinking it is present down in the middle lobe? Are there some guys who do not understand this CT classification? Okay. Yes, no, guys? Right, I guess so. Now you guys already have figured out how to look at CT. So you see here, I am looking at the hazy densities. This does not look like pneumonia. Remember, you see here, this does not look like pneumonia. Yes, it is homogeneous, but also you see here, it does not have any air bronchocram pattern, right? And you see here, there are patchy opacities, but there are a confluent of patchy opacities that are specific only in a single segment. So, which obviously means to say I'm looking at aspiration. Did you understand? The CT actually shows a bilateral lower air space disease, okay, confluence of hazy densities that are present down in the superior segments of the lower lobes. Okay, this is the dorsal segment of the lower lobe, and it is happening bilaterally, right? So that's the reason I'm looking at a patient of aspiration. And you see here, since the patient is lying down in the supine position as we take down in a CT, so that's the reason all the fluid went down and settled down in the posterior regions. So this became the most dependent area. So that's the reason I can see it more posteriorly, and also it is seen down in the lower lobes if the patient could have aspirated the content while he was sitting upright. Okay. So the upright position of the lower lobes are affected. Okay, that's how it is, right? In recumbent position, the superior segments of the lower lobes or the posterior segments of the upper lobes are also most involved. And you see here, how can I differentiate if this is an aspiration or if this is a pneumonia? Pneumonia generally resolves with the treatment related to pneumonia, whereas the aspiration will be resolved and will clear eventually if I am generally if it is a water or if it is a neutralized gastric acid, okay, it will usually clear within 24 to 48 hours depending on the volume aspirated. Now, I think last time we have been talking about the patients of near drowning, right? I have been talking about a patient of drowning and how he presents up in the scenario, right? A drowning patient generally will have a fluid, the water is entering down into the tracheobronchial tree and eventually getting settled down into the lower lobes of the lungs. Let us say he has been in water for something around like only 1 or 2 minutes. Okay, when I pull the patient out, it is which is technically called as near drowning. Okay, I almost saved the patient did not die yet. Okay, so it is called as a near drowning patient. So let us suspect this patient is a near drowning. Now what happens, I will be putting up the patient for observation under 24 to 48 hours, and I am taking a radiograph once again, and if these shadows are gone, I can understand that I am particularly looking at out an aspiration. And if you have observed closely, aspiration is also most common condition happening due to mucus plug impactions in asthmatic patients with atelectasis, yes or no? So that patient is also risk. How is asthma being controlled? Now you tell me one thing. Let me ask you a very, very good clinical question here. Will you be giving bronchodilators to this patient? Will you give bronchodilator to this patient? Aspiration, there is a problem of aspiration, right? Which happen down into the lower lobes. So will you give bronchodilators because the patient complains dyspnea? Why no? Why no? Because that's where the problem started. Being wider the right main bronchus, right? Being more straighter bronchus. And I'm giving more bronchodilator. What happens? They become more wider, more fluid aspirate, more going deeper, and it will finally reach out the terminal bronchioles, and which will cause hemorrhages. Yes or no? It is completely destroying with your oxygenation capacity. Yes or no? That's the reason no bronchodilators. So what I'm going to give? I'm going to give only oxygen in this patient, right? And if it is a bigger foreign body, what I'm going to do is I'm going to do a CT guided or a bronchoscopic guided bronchograph bronchography, or I'm going to give out a bronchoscopy. Okay, CT guided bronchoscopy can be done in this patient. Okay, right? No bronchodilators to this patient. Bronchodilators cannot be given to this patient. So what are you going to give? You are just going to put under the patient for observation for 28 to 48 hours and see how much it is going to be remitted. Now, but if it is a pneumonia, we have to try to understand here how it resolves. Let me give you let us come back to the same clinical scenarios to our two little kids. Okay, one is the 5-year-old male and the 15-year-old male. Now the question comes, since I have made the diagnosis one as bronchopneumonia and other as only infectious inflammatory pneumonitis. Now the question comes down is that, okay, which treatment strategy should I give both of them? Okay, we have decided that one patient requires antibiotics and other patient does not require antibiotics. The 15-year-old patient requires antibiotics and the 3-year-old male does not require any antibiotics. I think that's what we have come to a conclusion before, right? Yes or no? Do you remember those cases yet? Did you remember, or do you want me to repeat their case history so that you can understand? Yes, no, guys? Okay, right. Okay. A 3-year-old male was presented down to an outpatient clinic with a complaint of dry cough, okay, and mild grade fever, okay, for the last 3 days. When I took an X-ray, I came to find out that there is a bronchopneumonic pattern. First thing. The second case is a 15-year-old male complains of a mild grade respiratory distress along with a productive cough for the last 7 days. He also has a fever. The patient did not get better with the empirical management. Now, I took an X-ray and I came to find out that there is a bronchopneumonic pattern. Both conditions are same diagnosis. The radiographs are written down as bronchopneumonia. Now I have to decide which medicine has to be given to which person. Both are your patients. Both are sitting in front of you. Let us say the father and the child came down. Both are waiting for your prescriptions. So now it's the responsibility of the doctor, based on this radiographic report, to write down the treatment. The treatment strategy will indeed control your resolution. Yes or no? Removing of pneumonia is called as resolution. So we also have to know how the pneumonia resolves. So now we have given medication. So which patient will you give which medication? Which patient will require antibiotics? First question, which patient will require antibiotics? Is it the 3-year-old male or is it the 15-year-old female? Oh, I mentioned them as father and child. Mother and child, let's say. 15-year-old female may require antibiotics. Okay. And what else with this 15-year-old female will be requiring? This 15-year-old female will be also requiring mucolytics and expectorants, right? And a little bit of bronchodilator like salbutamol or ipratropium bromide or terbutaline. But what about the 3-year-old male? What will he be requiring? Does he require any antibiotics? Anti-inflammatory. What anti-inflammatory will you give? Will you be giving? Will you be giving NSAIDs like paracetamol, acetaminophen, aspirin, celecoxib, itracoxib? Those are anti-inflammatories, right? Yes or no? Shafiq, Munib, what are anti-inflammatory medications? Non-steroidal anti-inflammatory medications, acetaminophen, aspirin, ibuprofen, indomethacin, celecoxib, eticoxib, those are the drugs are anti-inflammatory. Will you give that one for them? Okay, steroids. Steroids are contraindicated in a child. So which steroid are you choosing? Okay, I will talk about steroid, but first tell me other things first. Which is the main prescription? The main prescription I am going to include is the antihistaminics. Okay, since it is an histamine reaction, okay, since it is an inflammatory histamine reaction, yes, it is inflammation related to histamine. Inflammation not related to prostaglandins, inflammatory reaction related to macrophages, right? That is what it is. Yes, it is inflammatory, but you don't give anti-inflammatory. Anti-inflammatories are generally classified according to your interleukins and prostaglandins. But this one is not prostaglandins. This one is a 5H2 agonist, right? 5H2 receptors are being worked here. The inflammatory reaction is happening through neutrophils and macrophages. Yes or no, guys? Right? So that's the reason I will be giving out antihistaminics, chlorpheniramine maleate, pseudoephedrine, levocetirizine. Yes, if I'm thinking about a patient of pneumonitis, which eventually becomes asthma or a bronchopneumonia. So steroids, yes, I will be adding out uh, some hydrocortisone drops. Okay, hydrocortisone oral solution. And since it is a dry cough, so no mucolytic might be necessary in this patient. So I will be giving out an antitussive, which is a dextromethorphan, right? That is what my prescription is. But logically speaking, now a big question comes. Which of the patient needs down to stay down in the hospital? Which one of the patient needs to get admitted? Which one do you think? Do you want to make money and admit both of them? Or do you want to be really so human and send both of them home? Or do you want to take chances and say that, okay, I will admit the child and I will give out the mother, go home since she is elder? Or you are thinking that mother is bigger enough and she will pay more money and you will put in hospital? Who requires hospitalization? How is the doctor able to decide who requires hospitalization? Should I be giving medication in an outpatient or should I be giving medication in an inpatient? Okay, we will come down to that answer finally when we understand how the resolution occurs. See here, pneumonia can resolve in 2 to 3 days if the organism is sensitive to the antibiotic administered, especially pneumococcal pneumonia. Pneumococcal pneumonia is generally resolved within vacuolization, okay, generally disappearing in patchy fashion over days to weeks. So now I thought to give out an antibiotic only for 1 day. I forgot to ask this question as well. Okay, antibiotic given for 1 day, 15 days, lifelong, steroids, lifelong, right? See, I think you have known about the asthmatic patients taking down the steroids and anti-asthmatic medications lifelong. Yes or no? Right? But so when you are trying to give out the patient, yes, the patient's mother was so curious and as asking, sir, should I be giving down this medication lifelong? What is your answer? You should say it. We are going to see it, how you are responding. And how is it responding? It is responding over 2 to 3 days. If it is a bacterial infection, if you are giving down a specific antibiotic like a fluoroquinolone, or if you are giving out the streptococcus like amoxicillin and penicillins or cephalosporins, if you, and they should be resolved within 2 to 3 days. And how is it resolving? The patchy fashion, how it started centrifugally, central to peripheral, that is how it is disappearing as well, right? So, and it will happen over days or weeks. But generally speaking, on the first day itself, if you see that the patient has got a respiratory distress, less oxygenation, if there is a blood urea content less, if the patient has comorbidity conditions like diabetes, urea, okay, hyperuricemia, or any other clinical conditions, you are going to admit the patient because that is the one that determines the mortality in a pneumonia patient, right? Remember, and the first, when we are starting up the class, I told you that pneumonia patients have the high mortality rate, right? Almost 70% of the pneumonia are more likely to develop complications of pneumonia, which is exactly happening in COVID-19 patients also. They are more likely to develop a condition called as ARDS, or if it is happening due to a virus, they will be developing out a condition called as severe acute respiratory syndrome, which is called as SARS, right? This is the fashion, and it is an interstitial pneumonia as well. So that's the reason how am I deciding, right? See, what is our government doing right now in admitting down all these coronavirus suspected patients? Any patient suspected with the flu-like symptoms like mild grade fever, mild grade cough, and all other conditions, respiratory distress, cough, productive sputum, and as well. And what are we doing? Are we admitting down into the quarantine and observing from 3 days? Yes. And what happens in that 3 days in that side hospital? Yes, we are getting medications redirected towards corona. We are redirecting the medications. We are supplying them oxygen. We are supplying the empirical antibiotics, prophylactic antibiotics like broad spectrum cephalosporins, fluoroquinolones to prevent the community acquired pneumonia as well. And we are also giving more specific treatment, and we are also giving down a test called as RT-PCR, right? So that is what happening in 3 days. And in 3 days, if that pneumonia is resolving, yes, I am sending out the patient and I'm saying the patient recovered from corona. But if he not, what I'm doing, it is going down from over days to weeks. Did you understand how the government is working? Have you been following up all this? Right? I think maybe as doctors, you should be thinking about this rather than seeing when the quarantine closes or when the quarantine opens, and how to follow the social distancing, or who are, uh, destroying the social distancing. That's not what you should get in the news. As medical students, we should be thinking about what exactly is happening in those patients who are admitted down in the hospital. That is more interesting, I guess. Right? Clear now? Did you understand? How is radiology influencing the clearance? So what I am, yes or no, guys? Please respond. Right. Now, how did the doctor make is actually due to two types of clinical assessments called as CURB 65 score, okay, and POTS score, okay, POT score, okay. The doctor is dealing about this clinical condition, thinking about the resolutions based on two things called as the CURB 65 score and the POT score. Remember, CURB 65 score is used in the assessment of mortality rate that is associated with pneumonia. Okay, mortality rate associated with pneumonia. Severity of pneumonia assessment is made by CURB 65 and POT scores. Okay, and what actually I am doing here is that I am looking at the radiographs, I am looking at the clinical lab investigations, and I am finally deciding if I am admitting the patient or if I am not admitting the patient. I am also looking at the clinical condition of the patient and deciding which patient is more likely to die early or more likely not die. That is how I am deciding who will receive the treatment first, who will decide the treatment next. It will decide the mortality rates. It will decide my treatment strategy. It will decide who are more likely to develop the risk of complications. So that is how I am looking at who will get better, who will not get better, who will die, who will not die. That is what I'm doing here, and I am doing it in association with radiology. Get it? Okay. If you have time later on, once search down in the internet what exactly is this CURB 65 score and POT score. Okay. Later on, I will give you more clinical scenarios when we get down into cardiovascular diseases. Okay, I will talk about more of them there because pneumonia is happening in cardiovascular diseases as well. Tomorrow we can deal about it. So by tomorrow, try to find out what exactly that includes a curb 65 score and a port score, because the components used in these scores are generally associated with cardiovascular diseases. Okay, we are calling them as comorbidities. Did you hear that most of the old age people are the ones that die due to corona? And why are, I think in the news they have been telling that the old age people are the ones who dies more frequently, and it is happening just because the patients have a condition of heart and have a condition called diabetes, right? Yes, not immunosuppressed, not immunosuppressed. Those people are not all immunosuppressed. They are not immunosuppressed. They have a comorbidity. They have a comorbidity that is related to cardiovascular and pulmonary cerebral compromise. Immunocompromised patients will die first because of more damage to their immunity. But comorbidity patients are the one that are suffering a lot. Comorbidity conditions with the cardiovascular disease, myocardial infarction, congestive heart failures, cardiomyopathies, diabetes mellitus, cerebrovascular infarctions. All these patients are the one with comorbidities, and those are the patients that are suffering and getting and dying because of ARDS. Right? High ratio of the patients with respiratory diseases. Yes, community acquired pneumonias. Did you understand? So that's the reason you learn about curb score and curb 65 and port scores. Okay, port scores. Right. By tomorrow, because we are going to deal with cardiovascular system can be completed down in one day itself. And that's the reason, to understand cardiovascular system better, we will be understanding more about curb 65 and port scores. Okay. Right, let's not get into the news. Let's complete off the chapter. You see here, pneumonia, this one came down as the lingular segmental pneumonia because the left hard border is not seen here. And after the treatment, yes, with the antibiotics, you see here the patch has got complete, where this is a homogeneous density here, now became more of a hazy density. Yes or no? So after 2-3 days, no, which may actually suggest me that I have to continue down the antibiotics, but next coming 3 to 5 days, which will eventually completely resolve the patient, right? And most radiographs are generally taken 4 days apart. So a general prescription for a pneumonia patient will be 1 week. Okay, generally 1 week, 5 days to 1 week. And curb 65 score actually indicates if a patient is presenting up with a cough within 3 days, yes, an antibiotic is not necessary. And if a patient has been complaining of non-productive cough for more than 4 days, yes, an empirical antibiotic, a broad spectrum antibiotic is necessary. And if the patient is complaining a cough of 7 days with no sputum, yes, a more redirected radiograph has to be done and find out the etiological factor. But if a patient complains of productive cough for more than 15 days, a blood sputum examination should be done. Blood and sputum examination should be done and remove all the etiological factors likely to be causative organisms like tuberculosis and community acquired pneumonias. Is this clear? Or do you want me to repeat the whole sentence once again? Take a clear note of this one. If there is a patient with mild grade symptoms less than 3 days, no antibiotics are necessary, but the patient should be managed with antihistaminics or empirical management, symptomatic management. But if the patient complains of severe symptoms for greater than 4 days, okay, a chest x-ray graph may be necessary and give empirical treatment. But if a severe grade symptoms like cough with no productive sputum is present, the patient will be requiring a chest radiograph and an broad spectrum antibiotic may be necessary. Right, 4 to 7 days, a broad spectrum antibiotic may be necessary. But if a patient complains of 15 days of cough A chest radiograph is necessary, and it is also necessary to conduct a sputum and blood examination to find out the etiological factor. Is this clear? Because the radiographs are the one that decides what kind of a treatment strategy that you are picking up. Who requires an inpatient treatment, who requires an outpatient management, how many days of prescription, what antibiotic are you giving, is it giving you antihistaminics, are you giving bronchodilators, are you giving mucolytics, are you giving antitussives, are you giving oxygenation, are you giving humidification, are you nebulizing the patient? All these things have to be done and evaluated on a radiograph itself. This is not the job of a radiologist. It is the job of you guys, who the general physicians who are treating the patients, right? So try to understand this chapter well. The only reason why I have taken this very small chapter in very much detail is that because this is the most common condition that comes down to the hospital. Pneumonia is the only condition that will give out a chest radiograph. You know, you will be prescribing like hundreds and hundreds of radiographs every day just because of this one. Somebody aspiring to become pediatrician or somebody trying to become a pulmonologist, your life depends on this simple logic itself. If you understand this chapter well, I think yes, you will be making millions later on. But if you did not understand this chapter, but does not obviously mean to say that you won't become a pulmonologist as well. Okay, you will become. But I actually took a long time for this class, just the reason to let you guys understand the core of these details. Okay, right? Okay, in pneumonia, if the pneumonia does not resolve in weeks, you should be thinking of an obstructive lesion, right? You should be thinking of a lung cancer, generally bronchogenic adenocarcinoma, right? You should be thinking of it. But if pneumonia does not resolve, obstructing lesion, neoplasm, and a chest CT scan, you have to follow up with the chest CT scan. See, the thing is that tell your patient clearly why you are taking down a chest radiograph. Very few doctors talk. We are done with the respiratory system here. Okay, so we are completely done. Let me talk you a little about ethics and then we are done with the class. Always tell your patient why and what kind of medication you are writing. Always tell the patient why you are thinking to write a chest radiograph. See, most of the people think it this way. If a doctor is prescribing a test, which means to say he is not really clever enough. Okay, this is what happens in India. I don't know about African conditions, but this happens in India. If a doctor is writing a test, he is a very, very bad doctor because he cannot make a diagnosis without a test. Most of the doctors, because there are genius doctors who can actually make out a diagnosis, right, without just looking at the patient. He says that my RMP does it, make a diagnosis just by looking. Why are you writing so many tests? You have to clearly explain the patient that I am thinking about this disease. It is obviously about making money, but it is also the first thing, it is making money just because it is proving a lot of diseases. Investigations prove diseases and money is coming down as a collateral damage, as a gift. Okay, not just for making money. Most of the times it is justified. I will be annoyed if the patient complains of respiratory distress and I will be taking down a hand x-ray. That is making money. Okay, and I will be, the patient is complaining of respiratory distress and I am taking down a pelvic CT. The investigation has to be justified. You see here, you tell him why I am doing this CBP, why I am doing the complete blood picture, why I am prescribing a radiograph. No doctor talks to their patient about prescriptions. I wish you don't become doctors like that. I wish you talk to your patients and tell them what kind of a prescription, why you are writing, how you are writing. I used to do that, okay? But right now I don't treat any patients, but I encourage you guys to learn about and explain each and every part of your prescription to your patient. that is necessary. You should learn and try to adapt this strategy down in your internship and start that today itself because you are already in clinical college, right? Explain the X-ray findings, explain the side effects of the medicines, explain the treatment strategy, explain the instructions, what should be followed, explain when he should come back, explain how he will get better, explain how far he will be worse. It is just giving out a psychological help and support to the patient. A doctor's job is not to just write medication, because obviously you write medication. Even if I talk to patient, even if I don't talk to patient, I give medicine, yes, the patient lives, which happens in comatose patients. I don't even talk to comatose patients. Even if I talk, they don't talk. Or I talk to children, 1 month old child, I don't know what he is talking about. So in such kind of condition, obviously I'm giving medicine. Yes, obviously I know the patient is getting better. But what about the other people who can talk? And maximum number of patients you are going to deal with 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 them are able to talk. So they are going to burst up with your questions. Some people may cry, some people may laugh, and some people may even tell you that you are a very, very bad doctor, that you will make bad diagnosis. So do not ignore respiratory radiological diagnosis and clinical scenarios. Okay, I hope you understand it well, right? And yes, I think that's it for today. Do you have any questions? Right? See, I may sound like as if I'm exaggerating the situation, but that's the reality. Once you get into clinical practice, you will understand what exactly happens. Okay, so try to take it slow. You will learn more and more. Okay, right? I wish you learn more and more. You have any questions for today's session, right? And as a matter of fact, go to the internet, go to Radiopedia page, and try to find what are the characteristic features of COVID-19 interstitial pneumonia. You have understood this chapter, I guess. So right now, go yourself and explore yourself and try to understand, and tell your mom, dad, or whoever says that, okay, today these are the symptoms I found. I learned more about corona, right? Explore all the symptoms, talk to your neighbors and everybody and tell them, okay, this is corona, this is what happens, this is what happens. From this day itself, you are the best doctor in your community as well, even if you did not graduate. You talk more about corona, people will start admiring about you right now. Use this chance, right? Let us boast that we have known about corona, knowing it from the corona, like radiographic details, symptoms, diagnosis, treatment protocols, what happens in a hospital, everything, right? Right. So that's it. Nobody has any questions, I guess, right? Any questions, guys? Right. Okay. I will try to post about tomorrow's class timings by this evening. Okay. Most probably it will be in the afternoon, I guess. Most probably in the afternoon at 1 o'clock. Okay. We will try, but I will try to update it by this evening in the group. Right. So that's it for this class today. Have a nice day. Bye bye. Any doubts? Contact me in personal messages. Right. Bye. Yeah.